Good afternoon, and welcome to today's Lunch and Learn webinar for the Iowa Pediatric Mental Health Collaborative, Trauma-Informed Care, presented by Dr. Liza Wikle. My name is Coffee Dixon, and I'll be moderating the session today. I will cover a few housekeeping items before we begin. The presentation will be interactive, so please feel free to use the chat feature to submit your responses and comments. Following the presentation, we'll have time for questions. Please use the Q&A feature in the webinar toolbar to submit your questions. The webinar will be recorded and the link will be shared in the follow-up email. Instructions for how to claim continuing education credit will be uploaded to the chat section and sent in the follow-up email after the webinar. So without further delay, it's my pleasure to introduce our presenter today. Dr. Liza Wikle is a general pediatrician. She attended medical school at the University of Iowa and completed her pediatrics residency at Dell Children's in Austin, Texas. Training during a global pandemic and within a federally qualified health center launched her interest in trauma-informed care. She participated in an educational telementoring program about trauma-informed care through the American Academy of Pediatrics. She focuses her time teaching residents about advocating for patients and families in the clinic, at school, and in the community. Welcome, Dr. Wikle, and I'll turn it over to you.
Thank you so much, Coffee. Good afternoon, everyone, and thank you for being here virtually. Today, we're going to talk a little bit about trauma-informed care, which is a very big topic. I feel like every single slide in this could be its own hour-long talk, but we're just going to kind of go through the basics. I think it's important to point out that June is PTSD or post-traumatic stress disease awareness month, which makes this an especially timely topic. While PTSD is one outcome of trauma, most of our children that we work with every day in our clinics are not carrying that diagnosis. Instead, they'll present with abdominal pain, sleep difficulties, behavior concerns, poor school performance, anxiety, or developmental concerns. My hope today is that all of you will leave this webinar with a deeper understanding of the pathophysiology of trauma and use this as a scaffold to build a practical framework for recognizing trauma and supporting families in a way that promotes healing. I have no disclosures because I'm a general pediatrician. By the end of this session, you should be able to identify two major outcomes of the ACEs study, recognize common trauma symptoms and developmental impacts, and then finally provide practical recommendations to families using the 3 Rs and be able to identify when a child should be referred to a more specialized treatment. The ACEs study, or Adverse Childhood Experiences study, was conducted through Kaiser Permanente in the late 1990s. Researchers surveyed more than 13,000 adults about childhood experiences, and those included abuse, neglect, and household dysfunction. Examples of household dysfunction in this study included exposure to substance abuse, mental illness in the family, domestic violence, and criminal behavior exposures. They then looked at the physical and mental health outcomes of the adults later in life. They found a strong correlation between the increasing number of ACEs or adverse childhood experiences and worse health outcomes, even early death mortality. Subsequent state and community level investigations have confirmed this association and strengthened it. This pyramid pictorially demonstrates the proposed mechanisms flowing from historical and social conditions, ACEs, all the way through the disease and disability and premature mortality. We will delve into this pathophysiology of some of these steps in later slides. At the time that this study was published, the association between ACEs and disease was revolutionary because it linked the childhood experiences to adult health outcomes in a measurable way and quantifiable. Studies on ACEs in the population, both from the original Kaiser study as well as further investigations in the population, have consistently reinforced the two assertions. One, ACEs are common. Most people have experienced at least one adverse childhood experience, and 1/4 of respondents in that original study experienced three or more. Second, there is a strong dose-response relationship between number of adverse childhood experiences and poor outcomes, poor health outcomes later in life. This includes depression, substance use disorders, cardiovascular disease, obesity, diabetes, poor educational attainment, and premature mortality. Trauma is not just a mental health issue, it's a public health issue. When we talk about trauma, we are talking about the experiences that overwhelm a child's ability to cope. Here we see the different types of trauma response: positive, tolerable, and toxic. And on the left, and then on the right, you can see the pathophysiology of that trauma response, or the response of the body of the patient. There is positive practice of the internal alarm system of the body, which leads to brief increases in heart rate and mild temporary elevations in stress hormone levels. The hormonal cascade flows from brain structures, including the amygdala, all the way down to the associated behaviors, which commonly are referred to as freeze, flight, or fight. Serious but temporary stress exposures cause more epinephrine, norepinephrine, and cortisol release, but they are often buffered by supportive relationships, which promote oxytocin release, and that balances the whole system. Toxic exposures are associated with prolonged and severe activation of the stress response without the balance of the affiliate response. Importantly, trauma isn't defined solely by the event itself, but how the child's body and mind responds in the context of a balanced affiliate response. Two children can experience the same event and have very different outcomes depending on their genetic brain chemistry and developmental age. Pathophysiology. Let's talk a little bit about why toxic stress matters. The freeze, flight, and fright responses, they are adaptive and survival mechanisms. They evolved to protect us from immediate threats, such as saber-toothed tigers. However, the problems arise when the stress response remains activated over time. That chronic activation without that balance alters development. The research following the ACEs study to look into the mechanisms of that association have identified three major areas affected by toxic stress. One is the brain connectivity. Two is immune function and dysregulation. And then third is the epigenetic changes that stress has upon the DNA. Toxic stress can have lasting effects on the health, behavior, and the learning of the individual. So let's talk a little bit about the brain under stress. There are three key brain structures that are involved in the stress response. The amygdala is the brain's alarm system. The hippocampus is involved in learning and memory. And the prefrontal cortex is the executive function and impulse control. Chronic stress changes how these systems interact. There's increased amygdala activation and reduced activity in the hippocampus and prefrontal cortex. These neural networks are strengthened based on the number of times the fight or flight response is activated, how much stress the person is experiencing. In a sense, the brain becomes optimized for survival rather than learning and self-regulation. However, children have significant neuroplasticity, which offers opportunities for healing and recovery and a shunting of the brain response from the amygdala, the alarm, to the prefrontal cortex and hippocampus to focus more back on learning, memory, and impulse control. Supportive relationships and effective interventions can strengthen these healthy neural connections. Let's move on to the cortisol impact on inflammation and immune function. The chronic activation of the stress response leads to repeated cortisol exposure in the brain and the whole body. Over time, this contributes to immune dysregulation and inflammation. And the excessive cortisol release suppresses humoral immunity, which increases the risk of infection. It also promotes a pro-inflammatory state. This is where inflammation is chronic in the brain and the whole body, which can directly impact developing tissues in pediatric patients. Cortisol's impact on the brain and body helps explain why trauma is associated with chronic physical health problems, such as obesity, hypertension, in addition to the mental health concerns that come from repeated cortisol exposure. Finally, the most interesting thing, I think, the interesting aspect of the pathophysiology of trauma is the epigenetics. Trauma does not necessarily change the DNA of the individuals themselves, but it does change how the genes are expressed through epigenetic mechanisms, directly like on the DNA strands. During critical development periods, certain genes may be turned on and off, and these changes can influence future stress responses, behavior, physical and mental health outcomes. Research has identified epigenetic changes in the sperm and eggs of trauma-exposed individuals, both in human and animal studies, and has shown that these epigenetic changes from the sperm and eggs can be passed down into offspring of the trauma-exposed parents. Alterations in the stress regulation systems, including cortisol pathways, may be transmitted across generations. The effects of an ancestor's traumatic experiences may contribute to the health and behavioral outcomes years after the original toxic events. These findings provide a biological explanation for the historical and intergenerational trauma that's at the base of the pyramid we saw previously. And it can help explain why trauma can affect families and communities across generations. And honestly, if we go back to that, impact how families can treat trauma in their children in the future. So now that we know a little bit about the pathophysiology of trauma, let's link this to the patients that we interact with every day. I'd like everyone to think about a child you've seen recently with behavior concerns, anxiety, headaches, abdominal pain, specifically chronic abdominal pain, or school difficulties. How many of these children may have experienced trauma? Probably more than we realize. One of my favorite teaching tools in the trauma-informed care world and research is FRAID. It connects the pathophysiology of the increased brain activation, the cortisol, and the epigenetics into some symptoms that you will find on a differential diagnosis. Let's go through them. F, fits, frets, and fear. Oftentimes, you will have patients that you are concerned they may have generalized anxiety, social anxiety, or phobias. R, regulation difficulties. These often manifest as challenges with transitions, like going to bed or going to school, and or tolerating seemingly minor triggers or changes to the routine. A stands for attachment difficulties. These can be between the parent and child, the child and adult, other adults, or childs and their peers, or children and their peers. Children could be labeled as oppositional or aloof. Providers may be concerned about ODD or oppositional defiant disorder or an autism spectrum disorder. Y is for yelling, yawning, and yucky symptoms. Yawning represents the common sleep disruptions that occur in patients with trauma. Yelling is obvious. Outbursts kind of fit in with frets. Yucky can make us think of the teenagers that we see in clinic with nonspecific aches and pains and low mood. Those are the patients that you never want to ask a full review of systems of. E is for educational delays. Families may present to your office because they are concerned about learning disorders or ADHD. And then finally, D is for defeated or dissociative behaviors. These are a little bit harder to come by because they are internalizing symptoms and they often mimic depression or inattention. Each of these symptoms can be mapped back onto our knowledge of the pathophysiology of the trauma response. For example, the yucky feeling you could very well stem from a hyperactive cortisol response from a complex repeated trauma that leads to immune dysfunction, dysregulation, recurrent infections. Another example is how trauma focusing the brain's connectivity towards the amygdala or alarm system can manifest as yelling, regulation difficulties, and fits. What's striking is that these symptoms overlap with diagnoses that we see and we treat every day. So, as pediatric providers, we must ask ourselves, is this ADHD? Is this anxiety? Or could trauma be contributing to the picture? I would be a bad general pediatrician if I did not comment on how trauma impacts development. Here are the main principles of how trauma impacts development to remember when you're conducting an assessment of a child with developmental delay or difference. Children with trauma often act younger than their chronologic age. In teens, this can be the opposite, with some significant adultification in their behaviors or risky behaviors. The most recently acquired skills are the ones that are most disrupted by traumas. For example, if you have a newborn with significant neglect, they may have feeding issues or a delay in social smiles. If you have a toddler with stressors, behavioral regression can be prominent. Next, developmental competencies, they build incrementally. So trauma impacts have a cascading effect. You could see a more significant and pervasive developmental delay in children with complex trauma early in their life. Trauma without buffering impacts developmental skills that are dependent on, and that is a new phrase here, SSNR, safe, secure, nurturing relationships. Um, Trauma without buffering impacts the social, emotional, and cognitive and language skills before it would impact gross or fine motor skills. So, whenever you are working up a child with expressive language delay or a high MCHAT or concern for autism, consider about trauma, which is impacting the social development of that patient. And then these repeated traumas and repeated developmental delay result in underachievement and um, low expectations for the patients. So this brings us to the practical question. We've talked a little bit about the symptoms and the differential diagnosis of patients that have trauma. And we've talked a little bit about the developmental disruptions that you may encounter as well. But what do we actually do with this information? Do we screen for ACEs at every visit? Do we use ACE-based risk stratification for our patients? Do we screen every child? What interventions are helpful, and are these interventions even available in our community? These are some of the practical implications of trauma in practice. The answer begins with relationships. It shifts the discourse from what's wrong with you, which was the old school way of looking at how a medical condition or mental health condition is presenting, and it shifts it to what happened to you, which is like the ACEs listing a whole list of traumatic experiences, and it shifts it to what is strong with you. Safe, secure, and nurturing relationships buffer and shunt the cascade of the body's alarm system away from the freeze, fight, and fright and into the affiliate response. And this is dominated by the feel-good hormone oxytocin. So, what is relational healthcare? The formal definition is a little bit lame. It is the capacity to develop these safe, stable, nurturing relationships with each other. Relational healthcare is an important predictor of wellness across the lifespan. Research consistently shows that these positive relationships are among the strongest protective factors for children experiencing adversity by buffering that trauma response and promoting resilience. You can conceptualize relational healthcare with this public health pyramid. There are primary, secondary, and tertiary approaches to toxic stress. We all work within one of these buckets and kind of in between all of them. As a general pediatrician, my goal is to work in the primary prevention arm of relational healthcare. I also utilize screening to determine if targeted interventions or indicated treatments, secondary or tertiary, approaches are indicated for my patients. For the rest of my talk, we will frame treatment modalities in the context of these types of prevention. So let's start with a toddler case here. Matt is a 2-year-old presenting for a well child check. He's moving busily throughout the exam room, touching the otoscope and spinning on the stool. Mom exclaims in a frustrated tone, "He is just bad. Get down. Didn't I tell you to stop touching things?" How can we as pediatricians use this situation as an opportunity to promote safe, stable, and nurturing relationships? We may be able to focus on educating the mother on appropriate development, and modeling safe, stable, nurturing relationships within the pediatric office. The pediatrician could say, "He's so curious. I love that he wants to figure things out. All of my 2-year-old patients love my doctor toys. But Matt, I agree with you that agree with your mom, and we don't want you to get hurt." They could also utilize a reach out and read book that's provided at the well visit as a way to redirect the patient, so being pretty functional in this setting, and show the mom how to incorporate early literacy principles to a very busy 2-year-old. Let's just say that this case continues on here. Your clinic just heard a fascinating talk about trauma-informed care and is now considering incorporating trauma screening for children presenting for well child visits. How would you screen Matt? Would you consider ACEs screening through a questionnaire on a clinic iPad or device? Or would a paper version with open-ended questions be more appropriate? Let's just say don't do ACEs screening. One of the biggest misconceptions is that the ACEs screening predicts outcomes for individual children or patients. It honestly doesn't. There's no predictive value or specificity in utilizing ACE scores in the clinical setting. It also focuses on the what happened to you rather than how are you functioning and what are your strengths. It is not symptom focused. While ACEs are useful at a population level and for research, they aren't really useful in daily use or in a clinical setting. Instead, I prefer simple questions that you can verbally ask or you can have in a questionnaire that you already use. One of them is, has anything bad, scary, or upsetting happened recently or since the last time I saw you? And another one that can elicit some trauma is, has anyone important left home recently? These questions are often more clinically useful and are honestly a bigger bang for your buck. You can also consider more formal screeners that are validated for PTSD symptoms, such as the Pediatric Trauma Stress Screening Checklist tool. It's got like multiple different names. Um, we will talk a little bit about that screener later in our talk. If you are not consistently or universally screening for trauma in your practice setting, don't fret. Providers for pediatric patients are often screening for overlapping symptoms, such as depression with the PHQ, anxiety with the GAD-7, and in developmental delays with all of the many developmental screeners available. If you are providing trauma-informed care through a relational lens, it's always important to put these screeners in context of the patient in front of you, and always keep traumatic experiences as a part of the differential diagnosis when considering further diagnostic workup, especially if any of these screeners are positive for concerns, or honestly, if the parent has concerns. So, case continued. Mom says that about a month ago, they had someone break into their house at night while everyone was sleeping. No one was hurt, and the intruder ran away. Matt did wake up when the police were called, and the mom admits that she's been quite stressed since this time. He has acted like himself since that time, and you assess that he is developmentally appropriate. Here's where we're going to use the webinar chat. Please message in, would you refer this child for therapy today? Answer yes or no. See if anybody has anything coming in. Coffee, do you see anything coming in the other chat?
I don't see anything yet.
That's okay. This is my first time making everybody message
Oh,
in.
people are raising hands, I
Oh,
see, as a response.
oh, let me see here. Oh, yeah,
So
more.
perhaps that, oh, and they're also putting them in the question box. Maybe the chat isn't enabled for them.
Do
So
you
I
see,
see,
Coffee, do you see? Are people saying yes or no?
yes, people are, oh, so I have yes, no, no, no,
Okay. So mixture.
no, yes.
Mostly
So,
no's. Awesome.
yeah, kind of a mix of yes and no's. I would,
Hold on, hold on. I'm sad that I can't see it. I have
and I
another.
apologize that the chat people aren't able to access
That's
the
okay.
chat.
No worries. I actually would agree to say that I wouldn't send this kid for therapy because while he did experience the trauma, he is functioning well. However, we don't just throw that mom out to the wolves. We give her some great kudos because he is not having any externalizing behaviors from that traumatic experience, likely because he has a safe, secure, and nurturing relationship with her. And she's honestly providing buffering for him. I would, but oftentimes I have families in clinic that ask about what they can do for their children that experience big changes in their lives or traumas like Matt. For the little kids, I tend to discuss the three R's. And then for older kids, there's a couple or more R's that can be good tools for families. So let's start here. The first R is reassure. So let the child know that they are safe. This can be done verbally or even with a physical touch and hug. The next R is return to routine. And this is something that I talk about every single day in my clinic, and I'm sure you guys all are as well. This helps patients know what to expect and when, and that helps them better regulate their emotions to tolerate transitions. And then that flows nicely into the regulate, which is ways that the safe, secure, nurturing relationship caregiver can discuss, read, and watch developmentally appropriate stress reduction techniques, such as breathing or yoga. For adolescents, we talk about those three R's, which are reassure, return to routine, and regulate. But then also, you have to take into account their more advanced processing in their development. So you can also add recognize, which helps teens identify changes in their mood and behavior and connect that as signs of how something may be troubling them. And then finally, relate, rebuild, which is a way that you can bring connection by showing interests in their lives and their own interests. So, off probably Matt didn't have a lot of behavioral issues or external or internalized symptoms of trauma because mom was focusing on all of these things for him. Okay, let's expand this case on a little bit. Matt has a teenage sister named Matilda who also witnessed the break-in. For the last month, she has had difficulty falling asleep and has had trouble focusing in school. She's failed tests. She's had nightmares of people breaking into her home and school and harming her. Okay, Coffee, you might have to help me with this one. What diagnoses might she receive if trauma was not considered with these symptoms?
Okay, I'm pulling up the Q&A. And I did send a message to everyone to put their responses in the Q&A.
Can I see the Q&A, Coffee?
Yes, you can pop it out like you did the chat if you want to do that quickly.
There it is. Oh, that's going to be helpful, I think. Yes. Okay. Pop it out. I think that will work. Let's go back to presenting. Nah, it
Okay.
didn't work. Whatever. You can tell me what they say.
Okay. Okay, we're getting um, GAD,
Yep.
ADHD,
Yep.
adjustment disorder, anxiety, adjustment disorder with both anxiety and depression, anxiety, um, another anxiety, generalized anxiety disorder, insomnia, ADHD.
You guys, those are all the things I had listed, but I also didn't have adjustment disorder, which I think is maybe the DSM-5 version of trauma. So, okay, cool. And then what are some of the screening tools that we could utilize to evaluate Matilda's concerns?
The scared,
Perfect.
the GAD-7 and PHQ-9.
Perfect.
Um, Depends on age, maybe the scared screener, GAD-7, and maybe PSC.
Love it. Cool. I don't think it would be wrong to use any of these screeners in this situation because they're all symptoms focused. But just be careful that you aren't automatically just diagnosing somebody with something without considering trauma and some of the treatments we have for trauma going forward. Okay.
There was a mention of the Vanderbilt
Yes, that is
and
also another one.
and the checklist, Pete's checklist. Is that one?
Yeah.
Okay.
This pediatric trauma symptom checklist specifically. It is very much so like the Vanderbilt screeners in that you are able to visually see the dysfunction, and the symptoms are based on the DSM-5 for PTSD. There are screeners available for younger patients, 6 to 10 years, and those have parental forms. And then there's forms for older patients, which are 11 plus. These are Matilda's responses. So you can see that there is a significant weight of the responses to the right, which indicates a more severe phenotype or impact of her trauma based or her trauma symptoms. So now that we know that she has some significant symptoms, how do we decide next steps and when to refer? So the biggest thing is if these trauma symptoms are impacting their quality of life. So you must ask yourself these three questions whenever a family brings this up to you or you elicit this question, elicit some traumatic experience. They have to have a presence of trauma. They have to have a marked change in their functioning, and then they have to have an impact on multiple areas of their life. If the answer is yes to all of these, then treatment is often warranted. But you should always consider that sometimes the dysfunction may surround a specific type or a specific part of the patient's day routine that the trauma may have occurred. So, for example, if there's significant school refusal after a bomb threat at school, but they're functioning okay at home, that is the caveat in trauma. So, as you can see here, the screening had identified the need for that tertiary intervention on that public health pyramid. So, the next steps, this is kind of the bulk of what I think people are interested in. There are evidence-based therapies that exist for trauma symptoms, and they're pretty effective. The most highly recommended treatment for PTSD or trauma is therapy. Here are a couple of the options. One of them is trauma-focused CBT, and it's generally my first recommendation. It's indicated in children 6 and up and has the most data behind it. This would be a good, this would be a good option for Matilda, the teenager, given her age and her symptoms. Trauma-informed principles recommend a warm handoff when possible to the therapist from the referring provider in order to provide useful background on family dynamics and the trauma indication for the referral. In a perfect world, this occurs within a clinic that has dedicated mental health specialists to ease barriers to care. For younger children, the child-parent psychotherapy modality can be particularly effective. This therapy modality is interesting in that the client is actually the relationship between the parent and child. If Matt, the 2-year-old, was having significant behavioral outbursts or regression linked to the traumatic experience, this could be an appropriate modality for him. There are other therapy modalities with trauma evidence for. One of them is parent-child interaction therapy, or PCIT, and the other one is EMDR, or the eye movement desensitization reprocessing. Each of these modalities has different treatment timelines and are emotionally time intensive for parents and patients and families. Medication management for trauma symptoms is difficult. You may feel pressure to prescribe, especially if the family and the child have significant dysfunction. Families also feel significant pressure from school, asking for more tools to help with externalizing behaviors. They also may be convinced that this is ADHD, now that there's more social media content about ADHD behaviors. Furthermore, complex trauma with multiple symptoms can fit into multiple overarching psychiatric diagnoses, leading providers to feel the need to medicate for each specific diagnosis, leading to significant polypharmacy. Because there's different underlying brain chemistry due to the pathophysiology of trauma, some medications may not work like you would expect, and specifically if they're utilized in young children. I think if you take anything from this, please do avoid benzos and antipsychotics in these patients. The most important thing to remember is that no medication treats trauma itself. Currently, there are no medications that have been truly proven effective to be approved by the FDA for PTSD in children. That doesn't leave you with a lot, but you can try to augment and target the sleep symptoms that often are pervasive in patients with trauma. And you can do that through psychoeducation about the importance of routine, just like the 3 R's that we talked about, and or targeting screen time, encouraging a decrease in caffeine intake. There are some providers that will trial melatonin, with the caveat that occasionally melatonin can cause nightmares, which overlaps with trauma symptoms. And then some providers utilize prazosin like they do in adults for PTSD, specifically for sleep. A final note, I want to remind everybody that primary prevention often and commonly happens outside of our clinic walls. And if you think Matt and Matilda's mom, I think about that case we talked about, if Matt and Matilda's mom didn't have transportation to the clinic, then they would never be able to build a provider-family relationship, and trauma screening is never completed and they're never referred anywhere. So these factors contribute both to the adverse childhood experiences as well as the ability for families to participate in the treatment and healing through relational care. These include, but are not limited to, housing instability, food insecurity, community safety, and culturally appropriate care. These factors often influence outcomes far more than anything we can prescribe or one-on-one therapy can treat. And we must fully understand the context of our patients, where they're coming from, in order to engage in relational healthcare. So if we're going to review my take-home points, is that ACEs are common. Trauma changes developing brains and bodies. Trauma symptoms are often frayed, and relationships are protective and healing. When trauma affects the functioning across multiple domains, referral for evidence-based treatment, specifically therapies, is often appropriate. And here's just a smattering of online resources that are available for further provider education and to provide resources to parents and families and patients. The American Academy of Pediatrics launched the National Center for Relational Health and Trauma-Informed Care earlier this year. There are loads of free webinars, infographics, and educational content there. For patients, I direct younger patients and families to the PC Care Training Center. You could just Google it. It is a practical guide to parents to target specific behaviors with specific tools. And it's from a collaboration between UC Davis Children's Hospital and the National Child Traumatic Stress Network, or NCTSN. And that NCTSN has been around since the ACEs study and has loads and loads of information as well. The younger children can be directed to the Sesame Street and Communities website. You can also just Google that. It has a whole informational section on traumatic experience resources, including ways to teach families how to do regulation techniques for younger children. And then for teenagers who universally have smartphones, there are apps that are available for structured CBT, like treatments and mindfulness. We do have to put a caveat on that these are not specifically for trauma, but there are benefits for learning regulation techniques. The two I have depicted here are Breathe 2 with the number 2, Relax, and Mind Shift CBT, and both of these are free. Finally, I encourage everyone on this call to consider the community resources available to you. Evaluate if they're available for your patient population, if they're accessible, and through trauma-informed and culturally competent principles, and if they are affordable for your patient population, i.e., are they covered by insurance? Each resource needs to be routinely vetted as there's frequent changes in insurance coverage, funding, wait lists, and many other factors that make implementing trauma-informed care a complex endeavor. Although this can be frustrating, remember children are inherently resilient, and even a little bit of effort you can do will go a long way to providing the wraparound relational health care and promote wellness for them. I would also like to plug the Iowa chapter of American Academy of Pediatrics, which will be coming out with a pathway for community-based advocacy in the next year or so, and that will help provide tools for providers in Iowa to best assess availability, accessibility, and affordability of community resources available for their patients. Thank you.
Thank you so much, Dr. Wikle. A very informative presentation. I appreciate all the information and resources that you shared. So now we'll take some questions. Please feel free to type your question into the Q&A, and we will cover as many as time allows. We did get a question about, can you mention the name of the screener that you showed again?
Okay, I put two different names on there, and I've caught it as I was saying that. Let me find it in my notes here. And it's embarrassing because my clinic is working on implementing it as well. So that's embarrassing, but it's got a really long name. So let me find it really quick here. While I'm looking for that, you can find another question, Coffee.
Yeah. The therapies that you mentioned, do you know, are these, how available these are and whether insurance pays for them?
Yes. So I've actually talked to our social worker in our clinic a little bit about them. And she says that most providers that do CBT have at least a little bit of awareness of the trauma kind of lens and trauma-informed care. And so, at least what we're doing is any of the providers that we're just generally sending our patients to for anxiety and depression, we are we are communicating with them and asking them about their ability to do the trauma lens. And that's where that warm handoff comes in handy, which I know is not super realistic. Not all clinics have a provider in clinic that can help with that. But from my understanding, a lot of the therapy modalities are listed in any of like a provider or a therapy provider's like CV or whenever you look at them on psychologytoday.com.
Okay, thank you. Um,
I'm looking for that thing still.
oh, okay. Do you want me to?
I'll just find it in my, it's correct in this.
Okay.
It's got the longest name. This is the Pediatric Trauma Stress Screening Tool, is what it's called. And it's if you Google it and you look up Intermountain Health, there isn't a you don't need a what's it called? You don't need to pay for it, basically. It's for
Oh,
free.
okay.
Yeah.
Great. Thank you. There was another question about the apps that you mentioned.
Yeah.
What were the names? They got the Mind Shift, but what was the other app that you mentioned?
Breathe to relax. And I will send out a like a PDF of some of these resources. Or like I can send Coffee, I can send you the slides and I'll make them more obvious.
Oh, that would be fantastic. Thank you.
Hmm.
Okay, this is a question from someone who's incorporated the ACE score in their paperwork. They said our agency includes an ACE score on intake paperwork before therapy. Would it be better to just ask the questions like you shared?
Yeah. I think there's been when the ACEs study came out, there was a lot of push to start doing something about it because it was such a big finding and people pushed to put ACEs into like day-to-day practice, which I think the thought process is there and what we should be working towards. But then there's been feedback from patients about feeling targeted and feeling like they are not the sum of their trauma. And so while it's important to know basically that there has been trauma that exists. And if you're a therapist, I'm sure you need to know a little bit more about the details. Patients have given feedback that they prefer to focus on the symptoms, which maybe is one way to kind of depersonalize the traumatic experience. But there has been feedback that the focusing on the symptoms is preferred by patients. So could be something you could consider, maybe having a more open-ended question, like the questions that I had before. Let me find them. Yeah, having an open-ended question so that they are able to express whatever they want to. Our clinic did a quick kind of quality improvement project where we had this, has anything bad, scary, or upsetting happened since the last time we met is like the first kind of question on that pediatric trauma stress screening tool. And then if you said yes to that, you would then do all the symptoms. But we often had, we have some providers that do child abuse pediatrics as well, and they knew their patient had trauma, like pretty significant trauma that we would consider pretty significant and things we would need to know, but they never disclosed that. So they would say no, and the provider's like, I know for a fact that that's not correct. But so it's all in the perception of the patient, if that is important to them for them to disclose in like a workup situation. So I think part of it is also educating the patient is like why we are asking these questions and how that helps us with our recommendations for them.
Okay, thank you. Are there some recommendations you would have for supporting children within a school environment?
Oh my gosh, who asked that? I actually also work within a clinic within the school district in Iowa City. I think that incorporating the patients in their natural habitat, not just at home, but at school, is a perfect community-based intervention. One, you can use the primary prevention of um, um, promoting safe, secure, nurturing relationships within the school system, teachers and patient and student advocates, but then also incorporating, for example, like school nursing or other people that may see these kids with trauma, some of their externalizing symptoms. So I think I love that person, whoever said that.
Hmm, great, thank you.
Mhm.
There was a person who um, was wanting to know about the referral list for counseling services, um, and what's the best resource for um, the counseling resources that you mentioned. Was it Psychology Today
Oh,
or
yes,
or
psychologytoday.com.
okay.
Yeah. Because we used to, as a clinic and as a practice, sorry, like have a list of providers, but there's always changing providers, changing wait lists for each of the providers, changing insurance coverage. And so it was very hard and time intensive to stay on top of it. And not all practices have a social worker dedicated to knowing everything. So that's often where you can walk through that website with your patient with you and like plug in their insurance and go through it. That being said, a lot of therapies are time intensive and expensive, and they don't pay well for Medicaid. So there's often a long, long wait for patients with Medicaid for therapies, just in general, much less like dedicated trauma therapies. Yeah,
Oh,
but it's psychologytoday.com, which I'll also put on the thing.
okay, great. Thank you. Okay, well, it looks like we covered all the questions that we had, so I'll close with a couple of housekeeping items.